Welcome to this explainer. Look, if you've ever managed a patient on warfarin, you already know that familiar tension, right? It's a phenomenal, literal lifesaver of a medication, but man, that narrow therapeutic window requires absolute precision. When those numbers start to drift, the clinical anxiety definitely spikes. Well, today we're going to completely remove that guesswork. We're going to break down a clear, algorithmic approach to managing warfarin-associated bleeding and supertherapeutic INRs, so you always know exactly what your next move should be.
Okay, let's dive right in by grounding ourselves in the clinical stakes. The magic number here is 5. Studies actually show that the risk of major bleeding shoots up substantially once a patient's INR hits 5 or greater. This is the critical threshold where our clinical radar needs to be hyper alert and where immediate decision-making becomes absolutely paramount. To give you a highly actionable mental model for emergency triage, we're going to step down from high-acuity, life-threatening bleeding to asymptomatic cases, and finally, look at aftercare. So we'll cover warfarin and bleeding risks, life-threatening bleeding, high INR without bleeding, investigating the root cause, and resuming therapy safely.
All right, Section 1, Bleeding Risks, Understanding the Baseline.
So the really crucial point here is that bleeding risk isn't just about an out-of-control lab value. The risk of major bleeding is inextricably linked to the degree of anticoagulation, sure, but also to patient characteristics. I mean, even patients perfectly within a therapeutic INR range can face increased bleeding risks. This is absolutely true for those older than 70 or folks with underlying comorbidities like heart failure or kidney disease. Remember, you are treating the whole patient, not just a number on a chart. Moving into Section 2, Life-Threatening Bleeding, High-Stakes Management. Now we enter the high-stakes adrenaline-pumping scenario. Here is your immediate emergency protocol. When a patient is actively hemorrhaging, you need rapid, full reversal of the warfarin effect. Step 1, obviously, stop the drug immediately. Step 2, administer 10 milligrams of vitamin K via a slow IV infusion, usually over 20 to 60 minutes. But you know vitamin K takes hours to synthesize new clotting factors, right? That's exactly why you need Step 3 for an immediate fix, hitting them with an unactivated 4-factor prothrombin complex concentrate, or PCC. Now, what's really interesting here is exactly why 4-factor PCC is preferred over traditional fresh frozen plasma, or FFP. PCC offers rapid administration in a super small volume, which gives you immediate INR reversal. We're talking often within 30 minutes. FFP, on the other hand, it requires thaw, which just eats at precious time in an emergency. Plus, it requires a massive volume of fluid to get those same clotting factors, bringing a really dangerous risk of volume overload, especially in your older or heart failure patients. When you're actually administering that PCC, we highly suggest using a fixed dosing strategy rather than trying to do complex weight-based calculations. Why? Well, in a high-stress emergency, fixed dosing is simply easier to use. It gives you a faster door-to-needle time, improved clinical hemostasis, and an even lower volume of product given. The data is super clear on this. Utilizing fixed dosing for PCC leads to excellent clinical outcomes, including reduced mortality and way fewer thromboembolic events. Basically, keep it simple and keep it fast. Okay, Section 3. High INR without bleeding. Managing asymptomatic patients. This matrix right here is going to be your absolute best friend for asymptomatic triage. It takes literally all the guesswork out of the equation. Notice how we adapt based on the numbers. If the INR is under 4.5, we just omit or slightly reduce the next dose, completely avoiding vitamin K. If it's creeping between 4.5 and 10, we temporarily hold the drug for a dose or two, and a small dose of oral vitamin K is optional. But notice how we aggressively withhold the drug at an INR over 10, holding it until they're therapeutic again, while giving 2.5 to 5 milligrams of vitamin K. For these asymptomatic patients, do not use PCC or FFP. Instead, rely on oral vitamin K. Look, when a patient isn't bleeding, you actually have the luxury of time. Oral vitamin K effectively and safely lowers the INR within 24 to 48 hours. And crucially, choosing the oral route completely eliminates that small but very real risk of anaphylaxis that comes with an IV push. We do, however, have a much lower threshold to administer that oral vitamin K if the patient has specific conditions. Things like older age, a very high initial INR presentation, a lower weekly maintenance dose, decompensated heart failure, or active cancer. These are factors known to slow down the spontaneous lowering of a supertherapeutic INR. So if your patient checks any of these boxes, giving that oral vitamin K becomes a much more compelling choice to get that number down safely. Moving on to Section 4. Investigating the root cause,
finding the trigger. Once the immediate danger is handled, the detective work begins. And here is a fascinating medical detour. What if your patient's INR just won't budge? If a patient requires massive doses of vitamin K, we're talking sometimes 50 to 800 milligrams a day for an extended period, you absolutely must consider superwarfarin poisoning. These are long-acting rodenticides, commonly used in rat poison, that are literally up to 100 times as potent as clinical warfarin. Exposure can be accidental, intentional, or even happen when street drugs, like synthetic cannabinoids, are laced with the poison to potentiate their effects. Crazy, right? Returning to more typical cases, though, remember that a GI bleed or hematuria in an anticoagulated patient might actually be unmasking a hidden anatomic lesion. Think of it this way. The warfarin didn't cause the colon polyp or the bladder cancer, it just made it bleed enough for you to actually notice it. So always evaluate for underlying tumors, cysts, or infections just as you would for a patient who isn't taking an anticoagulant at all. And this brings us to a strict, non-negotiable rule for the ER. If your warfarin patient suffers even mild head trauma, get a CT or MRI immediately. Do not wait around for focal neurologic symptoms to appear. Studies actually show that up to 25% of anticoagulated patients with head trauma may have intracranial bleeding with a completely normal neurologic exam. This is a true medical emergency, for sure. Now, for your everyday asymptomatic spikes, you really need to channel your inner detective. Talk to your patient. Ask them about medication errors. Did they maybe mix up their pill colors? It happens all the time. Check for new interacting prescriptions or even over-the-counter remedies. Ask about recent dietary changes affecting their vitamin K intake. Even metabolic shifts, like a recent illness causing decreased intake or diarrhea, can drastically affect drug absorption and throw off that INR. All right, our final section, Section 5, resuming therapy safely post-hemorrhage care. This is the ultimate question we face. When is it safe to restart anticoagulation after a major bleeding event? How in the world do we weigh the terrifying risk of rebleeding against the silent, looming threat of a fatal thrombosis? It's a really complex risk-benefit calculation that heavily depends on the patient's underlying conditions. When it comes to resuming therapy, specifically after a GI bleed, the data reveals a really compelling trade-off. The numbers show that while resuming anticoagulation absolutely increases the risk of a recurrent GI bleed, it significantly reduces the risk of thromboembolism. And the most vital takeaway here, resuming therapy actually improves the patient's overall survival rate. It's a calculated risk, yeah, but one that statistically saves lives. Depending on the patient's indication, an unexplained INR spike or a recent bleed might actually be the perfect catalyst to transition them to a direct oral anticoagulant, or DOAC. Medications like apixaban, rivaroxaban, or dabigatran generally confer a lower risk of major bleeding compared to warfarin. Most importantly, they carry a specifically lower risk of intracranial hemorrhage, which, as we know, is often the absolute most feared complication we face in anticoagulation management. By internalizing this algorithmic triage, you can literally replace panic with absolute precision. So I'm going to leave you with this final thought to chew on for your next shift. How will you adapt this mental model the next time your patient presents with an INR above 5? Thanks so much for joining this explainer, and we will see you next time.